Welcome everybody. This is exciting. We have a full house. So welcome back to our seminar series. And today we have Dr. Andrew Peregrine giving the first talk in the series. So I know everybody knows Andrew quite well, but I'll just give you a little bit of an introduction. So Andrew obtained his DBM and PhD degrees from the University of Glasgow. After that, he moved to Nairobi, Kenya, where he worked for 9 years in the International Laboratory for Research on Animal Diseases. Then, in 1997, he joined the Department of Biology, and he teaches clinical parasitology and researches the epidemiology and impact of parasitic infections. He's also involved in the development of parasite control programs that minimize the rate of development of drug resistance. Andrew is a chartered diplomat of the European Veterinary Parasitology College and the American College of Veterinary Microbiology. And today, Andrew is going to talk to us about pathogen and primarily pronounced Echinococcus Multilocularis.
Okay, thanks, Sarah. Good morning, everyone. I should just point out the Dean's office asked to video this and to stream it live out on the website. So anything you say or do or snore will go global. So that will be why at the end, and please feel free if you've got questions as we go along to interrupt, but at the end when there will be time for questions, I will repeat your questions so they can hear them, if that's okay with you. Thanks for coming out. If you asked me what 3 parasites frighten you most, easily one of those 3 parasites would be this one, Echinococcus Multilocularis. What I want to do today is a number of things. I want to just give you a brief introduction or perhaps a reminder of some distant memories from when we went through vet school about this particular parasite, its life cycle, how it develops, what it does in those that it infects. I particularly want to tell you about the disease in people because it's a significant zoonotic issue. And then want to tell you about what's been happening in parts of Europe over the last 20-25 years, where this is very much, interestingly, an emerging issue. And then I want to come back to North America, and particularly to Canada, to tell you what's been happening, what we've been observing for the last 6 years. And I want to finish by asking you, should we be concerned? And I'll come back to that question a little bit later. So, firstly, what is Echinococcus multilocularis? It's a tiny little parasite, a tiny little tapeworm, in fact, that lives in the small intestine of both domestic dogs and particularly wild canids. These are the contents of the small intestine of a dog. The contents has been cleaned out significantly. You can see these structures, they're tiny. They're no more than a few millimeters in length, and if you put them under a microscope, this is what they look like. It's the classic appearance of a tapeworm with a scolex at the front end, so that's what it uses to attach to the mucosal surface of the small intestine. Behind that is a germinal epithelium that keeps producing segments. But this parasite only has a limited number of segments, which is why it's so short. The largest one is the most mature. It's full of eggs, which are released usually into the intestinal contents and then pass out into the environment in feces. So what's the normal life cycle? If you go to the textbooks, and if you went to vet school in the last 50 years, this is what you will have been taught. It's primarily a wildlife parasite, which is why when I came to Canada 17 years ago, I thought I'd never be talking about it. I thought people like Claire, you would be the person that talks about this. I deal with domestic species, and that's it. It's a wildlife parasite that primarily infects the small intestine of wild canids, so foxes and particularly in North America, coyotes. So they have these adult tapeworms in their small intestine and they shed eggs into the environment. For the life cycle to continue, those eggs must be ingested, and it's typically by various wild rodents, particularly voles in parts of North America. What then happens? What then happens is in the intestine of these wild rodents, these eggs hatch, the structures inside then burrow through the wall of the gut and pass via the portal circulation to the liver. And once they're in the liver, they produce small cysts, and then they behave like a tumor. Because in the liver of these wild rodents, these small cysts undergo what's called exogenous budding. They bud outwards. they end up producing these substantive lesions. So this is a lesion in this rodent. Here's similar lesions here. They're multicystic structures, and they are the intermediate stage of this parasite. The disease they cause, which results eventually in the death of these animals, the disease is called alveolar echinococcosis. The adult tapeworms almost never make wild canids sick. The intermediate stage causes typically death eventually, the disease of alveolar echinococcosis. So how do wild canids get infected? Shouldn't be surprising, by eating infected rodents. That's the life cycle as it typically occurs. Dogs and cats can get infected with these tapeworms in their intestine. How? They get infected if they ingest rodents in the environment. So if you live in a part of the world where this occurs, if your dog and cat never goes outdoors, this isn't an issue. But if they do and they hunt and consume wild rodents, then they could potentially get infected and then shed eggs into the environment. What else is important to appreciate about this life cycle is that there are a number of species, especially people, that if we ingest these eggs, these various species, including people, also develop the intermediate structures in their livers, just like this. Are human infections a concern? Absolutely. You'll see how much of a concern in a minute. If people get infected, it's classically by ingesting eggs in the environment. And just like those wild rodents that I mentioned, once you ingest those eggs, the parasites hatch and pass typically to the liver of people. What happens in people? Well, this is an emerging issue in Central Europe. I thought I'd just show you some images of a woman in Switzerland a few years ago, published in the New England Journal of Medicine. She was about 44 years of age, and over the previous 10 months, she'd been developing progressively more and more severe pain in her upper right quadrant of her abdomen. She was sent for imaging, and the image on the left is an MRI image. It's a cross-section of the upper part of her abdomen, so she's lying on her back, all right? This is the spinal column here, all right? This is the spleen, but what's of relevance to us, this is the liver. That's what the liver should like on an MRI, look like if it's normal on an MRI image. You can see this is all very abnormal, multicystic in appearance tissue within the liver. Presumptively, because of where this woman was living, it was thought it was likely Echinococcus multilocularis. It was confirmed with biopsies, and because of that, where at all possible, the surgeons undergo resection of the entire lesion. All right, they resect it. That's the appearance of the liver here. You can see typically multicystic in appearance. Thereafter, this lady would have been put on daily treatment with either fenbendazole or mebendazole for at least the following 2 years. And there's usually a reasonable outcome. What's one of the concerns about this particular disease in people is the incubation period. It can take anywhere up to 15 years after you get infected before you become sick. And that's an important fact to remember. What's known about the mortality rate in people if you receive no treatment or you're inadequately treated? This is a review that was published in 1996, and there's no reason to think the data are any different today. The average survival 10 years after diagnosis is 29%. 71% of people, if they receive no treatment, are dead 10 years later. All right? The average survival 15 years after diagnosis is 0. The mortality rate for this particular infection in people, if you're not treated, is worse than Ebola, if that helps put things in perspective. The incubation period is completely different. However, unlike Ebola, treatment and surgical resection can be highly beneficial. This is a summary of some data from 110 people in Switzerland that had non-resectable, AE means alveolar echinococcosis, so the intermediate stage. So they had the non-resectable form, which is much more of a concern, but they were put on long-term chemotherapy. Right? And in this group of individuals, the 10-year survival after diagnosis is 80%. So treatment is highly beneficial. There's still a 20% chance you're going to be dead, all right, 10 years later. So I know where I wouldn't want to be in that group. The 16 to 20 year survival after diagnosis is about 70%. There's a 30% chance you'll be dead. So it's a lot better than no treatment, but it's still a concern. So what's been happening in Europe? Because this is particularly interesting, and we have lessons to learn from what's been happening there. This was a map that was published in 2010 of what was known about the distribution then of Echinococcus multilocularis in the fox population. So the dark red indicates where this parasite was known to occur throughout Europe. What this map does not show you is the hot spot, the high endemic area, which is the region of Switzerland, eastern France, southern Germany, and western Austria. A few years ago, the Swiss became increasingly concerned that they believed this was an emerging issue, particularly in people, and because of that, they carried out a retrospective analysis of all the human infections that had been acquired and diagnosed in Switzerland over the previous 50 years to try and determine whether there was evidence this truly was emerging, that it was getting worse. What's shown here is a summary of this study that was published in 2007. And they went back and they looked at data that was acquired right back to 1956. So it's a 50-year period. There already were 3 studies coming out of Switzerland from 1956 through to 1992, and they managed to access all the national data in Switzerland going through from 1993 to 2005. They went back and looked at all of the cases to standardize the case definitions, and asked the question, number one, how many cases were diagnosed over each of those periods? But more importantly, what was the mean annual incidence per 100,000 people in the population? This is, I think, the most interesting column here. So it's the mean annual incidence, so the number of cases per 100,000 people in Switzerland. And from the period right through from 1956 right through to 2000, there was no change. But in the 5 years after 2000, there was a significant increase in the number of human populations diagnosed in Switzerland. This is the mean age at diagnosis. All right? Remember, whilst the mean age is about 52 years, the incubation period is up to 15 years. So they were likely infected at least 10 years prior to that. But over that period, there's been no significant increase or decrease in the age at which infections are diagnosed. There's no association with sex either. I want to show you the same data, but presented as a graph. This shows, again, the number of cases per 100,000 people in Switzerland from 1956 on the left, right through to 2005 on the right. Each of those dots is the incidence for that particular year. All right, so the dot is the figure for each year, and then with data like this that tends to bounce up and down, the dark black line, so the black line, shows you rolling 5-year averages. It just smooths the data. And there's important things to notice. Number one, from the early 70s right through to the mid-1990s, the Swiss medical system was feeling great. There was a progressive decline in the number of cases being diagnosed annually. It actually was at its lowest in 1996, but it was at its highest in 2003, because after this period, that's when there was this significant increase. Now, I know many of you are sitting there and thinking, well, haven't diagnostic methods improved significantly over the last 10 years? Is this just not an artifact of better diagnostics? It's a valid question. They went back through all the cases and they've staged all the human cases exactly like you stage neoplasias to determine whether people are still being diagnosed at the same stage of infection or earlier stages. There's no evidence that this is as a result of diagnosing cases earlier, all right? There's no change in the stage of infection when infections are being diagnosed over this whole period. So it appears to be a genuine increase. Now, the obvious question that comes from that is, why? Well, it's known that the fox population in Switzerland is the definitive host. And so they asked the question, what's been happening to the fox population and the fox density over this 50-year period? What did they want for that? They wanted fox density populations. Well, the Swiss don't record that, but what they do record is the number of foxes hunters kill every year. And at the national level, that's considered a reasonable surrogate measure for the fox density in Switzerland. And so this is the number of foxes. The y-axis shows the number of foxes killed by hunters in that particular year, between 1956 and 2005. The data is presented exactly as before, with the continuous black line being rolling 5-year averages. What you can see are a number of interesting facts. They knew for a long time that there had been a significant decline in the fox population from 1968 through to the mid-1980s. That decline in the fox population was clearly associated with an outbreak of rabies. And so at that point, the Swiss government instituted a national rabies control program for foxes, and that is what is associated with this substantive increase in the fox population thereafter. This actually represents a 4-fold increase in the fox population. Now, the interesting thing is, if you look at when this increase in the fox population occurred and how that relates into the increase in the human cases, there's a lag of about 12 to 15 years, which is exactly the incubation period for this infection in people. This is an emerging issue in Switzerland at the moment, which is ironic since it has one of the most progressive medical systems and public health systems in Europe. Now that's fine. That's the fox population increasing significantly. Was there evidence that the foxes were infected with Echinococcus Multilocularis? And over the previous 20 years, there's a number of studies that quite surprisingly have indicated anywhere from 30 to 65% of fox populations, including those in inner urban areas where there's been a big increase in fox populations, there's a substantive proportion infected throughout the country with this particular parasite. Now that's Central Europe. That's a long, long way from North America. Or is it? And I'm going to come back to that issue in a minute. What do we know about the global distribution of this particular parasite? Well, it's shown here in this particular map, but I think what's relevant to us are the Americas. So it's classically an infection in the northern hemisphere, and in North America there's essentially 3 areas where this parasite has been recognized to occur. The only high endemic area, what's shown in this dark black here, is on the western coast of Alaska, and we've known that for a long time. We've also recognized that there's a distribution right across the Canadian Arctic, primarily associated with Arctic foxes. And then there's this distribution in the central area. I've drunk too much coffee today. Okay. Hold on to your hand with the other hand. A recognized teaching strategy. And the other distribution is this area in the central part of North America here, which I'm going to show you in a little bit more detail here. It's been known for a good few decades that this parasite occurs in wildlife in the southern portions in Canada only of Alberta, Saskatchewan, and Manitoba, and then in 13 contiguous states in the US. And it's been there for a long time, and over that period, a number of people have done surveys of wild canids, particularly in various US states, to determine the proportion of foxes or coyotes infected. It varies anywhere between 5 and about 89%. It's usually somewhere between about 20 and 30%. So it's a relatively common infection in wild canids throughout that distribution. What about Canada? There's not a lot been done. There was a study done a few years ago that, for those of you that are on the CVMA mailing list, got a panicky email about a year and a half ago because of this study, which is about the only one that's been carried out and published, in which people in Western Canada did a survey of 91 coyotes that they found, I think largely found dead on the side of roads, downtown Calgary and downtown Edmonton, inner urban areas, all right, in Alberta. All right, they did the study between 2009 and 2011. 25% of them found infected with Multilocularis. What were their conclusions? Don't think anyone disagreed with the first conclusion that it was a common infection in coyotes in the inner urban areas of those 2 cities. They said it was an emerging phenomenon, which some of us criticized because it's the only study that's been ever carried out. So it's a little unclear how you can say it's an emerging issue when you don't have any historic data for the same population. But it got a lot of media attention, and Bayer in particular looked very hopeful this could result in the sale of one of their tapeworm drugs, but I'll come back to that. One of the obvious questions was, well, this is a big concern because surely, therefore, dogs in this area are getting infected, and because of that, isn't there a zoonotic risk for people living in these 2 cities? They're valid questions. In light of all that infection in the wildlife population, both in Canada and the US, I think one of the important questions to ask is, how common is this infection in domestic species, particularly dogs, cats, and people in North America? Until 2009, what had been published about this infection in those two domestic species and in people? And this is very interesting. Number one, outside Alaska, until 2009, there hadn't been a single dog described in North America infected with Echinococcus multilocularis. Not a single dog, despite that substantive geographic location in wildlife. Number two, what about cats? It's a little bit different. There's been 2 cats described infected in North Dakota, 3 in Saskatchewan, both back in the early 1970s. Common infection? Certainly not on the basis of what's in the literature. What about people? If you look at people outside the western coast of Alaska, with respect to infections that must have been acquired in North America, because there have been cases associated with travel and immigration, but as far as infections acquired in North America, as far as we can determine from the literature, there's 1 man in Manitoba, look at the date of publication, infection published in the 1930s, 1 woman in Minnesota, again, many decades ago. So it's not at all a common infection. That was the situation in the literature until 2009, particularly with respect to dogs. Not a single case described outside Alaska, anywhere in North America. In 2009, I got a phone call from a veterinarian working in a town called Powell River, which is on the west coast of British Columbia over here, and he was looking at a dog that had come to him with a family that was traveling in BC, but they lived in a town called Quesnel in the central part of British Columbia. It was a 3.5-year-old neutered Shih Tzu Bichon cross, and the history of this dog, that over the previous 10 days, whilst historically it was one of those dogs that bounces all around the house, all right, no longer was it jumping up on the furniture all the time, and it was starting to vomit quite regularly, and it was becoming weak and lethargic. The vet carried out a physical exam and palpated what clearly was a substantive lesion in the cranial aspect of the abdomen. He carried out ultrasound on this particular dog, and one thing particularly to note is the appearance of the liver, which is shown here. There's a number of odd features, unusual features. It's got an irregular surface, there's mixed echogenicity, and there's cavitated lesions within. In total, it appeared the lesion was anywhere up to about 13 centimeters diameter. He couldn't find any abnormalities elsewhere in the abdomen, and at that point thought, well, this is most likely some type of likely benign neoplasia. So he went into the abdomen because he thought, well, we'll just surgically resect it. And this is what he's found. This, what he removed, this is the liver, this is the abnormal tissue associated with it. That's the appearance on the other side. And I've shown this image to a number of pathologists in this department blindly and asked them, what do you think this is most likely? And everyone says, well, it's obviously tumor. Well, it was obviously tumor until the vet sent these tissues to a diagnostic laboratory in Canada. And it actually was at that point that the phone call came to me, because throughout this lesion it was very obvious this was not tumor, but it was a multicystic lesion, all right, with multiple cysts, very heterogeneous in size, all surrounded by significant areas of fibrosis. But what was more significant, to be honest, was what was inside. And this was the appearance inside most of the cysts in this lesion. Number of important things to note. Number one, these structures are called calcareous corpuscles. They're not associated with tumors, they're associated only with tapeworms. So straight away we knew this was a tapeworm structure. Number two, this structure here is called a laminated layer. It's PAS positive and has previously only been associated with Echinococcus species. These structures here are what are called protoscolices, and you may be able to appreciate hooks within these lesions. These are baby tapeworms. These are the hooks that are at the front end of the parasite. I was asked to look at this, and I was asked, what do you think this is? And I said, well, I've never seen it before, but to me it looks just like Echinococcus multilocularis. And I said, but I'm not going to make that diagnosis since this has never been described in North America outside Alaska. So then they said, well, what do you think we should do? So, following week, I happened to be at the World Vet Parasitology meeting in Calgary, where one of the researchers from the World Reference Lab for this, which is based at the University of Zurich and the University of Bern in Switzerland, a guy called Bruno Gottstein was coming. And I said, do you think I could show you some pictures? And honestly, Bruno told me afterwards he thought I was just pulling his leg and was wasting his time. But I'll never forget sitting down with him during one of the coffee breaks, and I showed him exactly this image, and his jaw dropped to the ground. And he said, this is exactly what we've been seeing in dogs recently, since the late 1980s in Switzerland. So I said, are you prepared to make a definitive diagnosis on the basis of these images? And he said, even I wouldn't do that. Can you send me some tissues for molecular analysis? And so this is their classic approach to confirm it. So we sent tissue the week after the conference, and then he subsequently sent me these data. On the basis of sequence data for this particular mitochondrial and RNA gene, the sequence was 100% homologous to reference genomic DNA for this particular parasite. On the basis of RFLP analysis of PCR products of these two genes, it matched identically to what they'd been seeing with reference genomic DNA from the parasite in Switzerland. And on the basis of direct immunofluorescence of the tissues we sent him, using an antibody they've generated that appears to be completely specific for this species. It doesn't cross-react with Echinococcus granulosus or any of the tapeworms that are recognized to occur in dogs. It was positive for that. And so Bruno came back to me and said, clearly this is a case of what's called hepatic alveolar echinococcosis, the intermediate stage of Echinococcus multilocularis in the liver of this particular dog. Now you may be sitting there thinking, hang on, didn't you show us this particular life cycle? And in this life cycle, you just told us dogs are definitive hosts. They have the adult tapeworm in their intestine. You've said nothing about the intermediate stage of this parasite in the liver of dogs. That's true. It's not in any of the textbooks, because it's a phenomenon that's only been seen since about 1989, and until this point, only in Central Europe, in a hotspot for this particular parasite. So they've started seeing it. I said to him, well, how do you think it occurs? And he says, we believe it occurs when dogs ingest massive numbers of eggs in the environment. So this dog in British Columbia must have ingested those eggs. Well, where did it travel to? Because at this point, this parasite has only been described in Alberta, Saskatchewan, and Manitoba. It's in British Columbia. So where did it travel? It's never traveled outside British Columbia. It must have got infected in that province. It must have ingested eggs in the environment somewhere in that province. So that's a problem. But that's a long way from Ontario. 2012, 3 years later, I got another phone call from another vet, but this time in southern Manitoba. He'd been handling a 4-year-old Labrador retriever, and the clinical history on this dog is that over the previous 2 months, it had becoming progressively weak and lethargic, and in the previous 2 weeks, the abdomen had become significantly distended. On the basis of imaging, they decided to do an exploratory laparotomy, and on the basis of what they found, the dog was euthanized on the table because of substantive liver lesions. They took a picture at the time and sent it to me, and throughout the liver there were multifocal lesions anywhere from a few millimeters to many that were 2 to 5 centimeters in size, and within many was this very characteristic necrotic fluid. This dog was worked up exactly like the first one. So there was histopathology done, and the tissues were sent to Switzerland. This was another case. So where did this dog got infected? Remember, the intermediate stage only occurs, as far as we're aware, typically by ingestion of eggs in the environment. Had this traveled? Well, it had to Alberta, and that was it. But that's okay. We knew the parasite had always in that location, so perhaps not too surprising, although what was surprising, this phenomenon had never been described in this area in North America ever before. So, but it must have got infected in one of those 2 areas. Later that year, I got a phone call from a bit nearer home, about 45 minutes away from here. So a practice in southern Ontario where a 2-year-old boxer had presented. It presented in the middle of the summer. You'll see the relevance of that in a second. And the history on this particular dog was very different from the other ones. It was a very acute history, and that it was fine the previous day, but in the last 12 hours, the 12 hours prior to being rushed into this particular veterinary practice, it suddenly had started standing rigidly still. It wouldn't sit down, it wouldn't lie down, it wouldn't walk. It just stood there. All right? And when they carried out a physical exam, it was very obvious that the abdomen was incredibly painful and tense. Imaging of this particular dog showed that the abdomen was full of fluid. They didn't know what it was at the time, and they rushed in and carried out an exploratory laparotomy. When they opened the abdomen was full of blood. And on close examination, it was clear that the blood was originating from within the liver. The dog was euthanized shortly afterwards, and this was the appearance of the liver at that time. Throughout the liver, there's generalized multifocal white nodules, anywhere from a few millimeters to multiple centimeters in size. And inside one of this particular part of the liver, there was a cystic lesion full of blood. It was about 8 to 10 centimeters in length, so they've opened it here, and this is where the blood was leaking from into the abdomen. Now, at this point, there happened to be, there's some fourth years here, one of your predecessors was, at the end of third year, doing their externship. We give our students, is it $200 to work up a case for diagnostic purposes, or it's about that?
It's $150.
Oh, it's dropped. Okay. Okay, maybe that's one of the reasons more of these not being worked up, Grant. Okay. So one of our students happened to be doing her externship there, and at that time, because she's watching this, she says, can we send the tissues for histopathology? Because I'd like to use this for my summer case and use my $150 for that. And the vets, I'm not joking, all in that room said, I wouldn't do that. You're wasting your time. This is a boxer. It's obviously a tumor. And she said, no, I'd like to spend it. And they had known, wait until you get a better case. Honestly, you're wasting your money. And that's literally the discussion that happened. She sent off the tissues finally, and one of Grant's people subsequently phoned me because the appearance of the liver was exactly as we've seen before. Tissues were sent to Switzerland, and this was confirmed to be the first case of this in southern Ontario. This is a picture of the liver. It's classically this multiloculated cystic structure, and you can see this very obvious hyaline membrane inside. There are no protoscolices inside this, but that quite often happens, especially in people. They're called sterile lesions. You don't get the protoscolics, but everything else is characteristic and was confirmed in Switzerland using all their molecular techniques. So this is a dog in southern Ontario. Where did this dog live? Well, this dog lived at the time of diagnosis just to the west of Niagara. So the obvious question, well, has it traveled? And they said, yeah, it travels to Manitoulin Island. But it's never traveled further afield than that. So where did this get infected? So I said, well, it must be Manitoulin Island. It wouldn't be southern Ontario, because we surely would have heard about this before now. And that was at that point in history. But it must have got infected in one of those two locations, remember, by ingestion of eggs in the environment. Remember, Ontario is a province. This has never been seen before in wildlife or domestic species. That was 2012. 2013, the following year, another boxer presented to another practice. This dog's completely unrelated, before you ask that question. Clinical history on this. This is very different. This is a healthy boxer. This boxer presented to a practice in Ontario for a wellness visit. It was standing there on the table. The vet was going to vaccinate it, and the text says to the vet, literally whilst they're holding the dog, this abdomen doesn't feel right. It feels as though there's multiple nodules or masses within it. And it was very clear there were multiple masses within this abdomen. One particularly large mass after doing imaging was in the ventral aspect of the abdomen, and so they did a fine needle aspirate, and as a result of that, went on to do an exploratory laparotomy. The fine needle aspirate, and there's a number of you who've been involved with these cases, produced this very unusual structure. Even clinical pathologists get excited when they see things like this because they're so unusual. These are folded basophilic membranous structures that, if you look in the literature, have only been described in fluid from the abdomen of dogs infected with Echinococcus multilocularis. All right? If you look carefully at this, you can perhaps appreciate a fairly granular appearance, but if you look under higher magnification, there are these mineralized structures called calcareous corpuscles. that have only been described in tapeworms. This doesn't tell you anything more than it's tapeworm, although in the abdomen of a dog, that doesn't give you many options. This, though, has only been associated with Multilocularis. So we're almost certain we were dealing with the case of Multilocularis. Turned out it was. It was confirmed in Switzerland. Let me show you this particular dog. Remember, it was healthy. The owner, for months, refused to let the vet do anything with this dog because she said, why would you bother doing anything with this dog? Because it's healthy. We did show them these pictures subsequently, which has helped. So in the ventral aspect of this abdomen, when they opened the abdomen of the dog, so the dog's lying upside down on the operating table, so they've made an incision down the middle, they've opened it up, there's this large fluid-filled lesion that's about 20 centimeters in length. Here it is exteriorized, and here's the vet removing, again, very characteristic necrotic fluid contents from inside this particular lesion. It was only when they deflated this lesion they could actually get into the abdomen, and this is the appearance of that particular lesion. I'm having problems with my pointer today. And throughout the omentum, you may be able to appreciate multiple lesions, anywhere from about 0.5 centimeter to 2 or 3 centimeters in size. So this has got a disseminated infection right throughout the abdomen. There were also lesions in the liver. That dog was sent home healthy. The owner wouldn't let them do any treatment for a while until we had some fairly long conversations with them. What's the long-term prognosis for this dog? At best, guarded. All right. What we have done, as is done in Switzerland, this dog has been put on daily albendazole, probably for life. All right. So that's to control the abdominal infection. The other concern is that in Europe, it's recognized that about 20% of the dogs with abdominal lesions also have intestinal infections. It's the intestinal infections that are a zoonotic concern because they result in eggs being shed into the environment. And to prevent zoonotic risk, you have to treat dogs once a month with a tapeworm drug called praziquantel. All right? So it's being treated with that as well. It's not cheap. All right? But this dog is still doing fine, as far as I'm aware, in southern Ontario. Where did it live? It lived its entire life in the Brantford area. It's never traveled beyond there. So that was the second case in Ontario, acquired in Ontario. Early last year, in February in fact, the third case presented, and actually was at OVC. Some of you may remember it. This was a 6-year-old male Leonberger. The history of this particular dog, it had come into an Ontario practice, and just for the previous week had just been weak and lethargic. It had lost a significant amount of weight, and the strange thing, very strange as you'll see at the moment, it was referred to the cardiology service at OVC because of an elevated heart rate, like a very elevated rate. One of our astute fourth years at admissions realized that probably the primary problem was not the heart, all right? Because this is the dog. There's a sizable lesion in the right axilla. When the owner was asked about this, and this wasn't even mentioned on the referral letter, by the way, there's a rather substantive lesion in the right axilla that's been growing for 2 years. As is done, fine needle aspirates were carried out on this particular mass. Again, these characteristic folded membranous structures and calcareous corpuscles. They actually did whole body CT scans, and I don't think you have to have much experience with reading CT scans to see the abnormalities in this one. So this is a cross-section of the thorax, all right? This is the thorax here. This is the mass on one side of the thorax. So it's lying in a subcutaneous location. It's heterogeneous in appearance. All right, and it extended the entire length of the thorax. The good thing about this dog, it seemed to be very well contained. There was no involvement elsewhere. This is a longitudinal section of that dog. That's the thorax. This is the abdomen. That's the mass. You can see it appears to have a cyst wall, and the surgeons therefore believed it was a good candidate for excision. And this was the surgery, removal of this cyst, which actually was done within about half an hour. I think it's the largest surgical biopsy you folks have ever received, weighing about 7 kilos in total. Within it, there certainly was a large cavitated fluid-filled compartment. The tissues were sent for histopathology, came back negative for Echinococcus Multilocularis. Our folks only do a limited number of sections, though. All right? It was sent for cestoid PCR, and the people in Saskatoon that we've also been working with came back and said this was positive on all their tests, which were subsequently repeated. Strangely, the people in Switzerland came back and said it was negative. And in honesty, the jury's out on this, but because the sensitive no PCR method is 100%, the working diagnosis at the moment for this is also Echinococcus multilocularis. Where did that particular dog most likely get infected? It lived its entire life in the Burlington area. Let me just remind you, the first one almost certainly, therefore, got infected in the Niagara region rather than up in Manitoulin Island, all right? And the second one in the Brantford area. The last thing that we've done with these infections has come about as a result of a molecular method that looks at sequence data for 3 genes simultaneously. It's a group in Japan that developed this method. They've looked at isolates from around the world and have found that using this particular method, you can group isolates in either to those originating from North America, from Asia, or Europe. What's the relevance of that? The relevance of that for us in North America, European genotypes are typically considered more pathogenic for people than the other ones. But we live in North America, so that shouldn't be an issue. Everyone thought it's obvious these infections that we're seeing in North American dogs will be North American infections. This was the mitochondrial haplotype network that these Japanese researchers constructed. It's basically carried out, for those of you that don't do this, like cluster analysis. And there's essentially 3 groups: European, Asian, and North American. Obviously, our isolates would be associated with North American ones. The first one, all right, associated most closely with the European ones. That's the case in British Columbia. The second one in Alberta and Manitoba, again, appeared to be European in origin. And the first 2 from Ontario that have been typed, they couldn't type the first one, but the second one typed, again, as European. European in southern Ontario? How did that happen? So let me just give you a summary. To date, the 3 that have been typed all appear to be European in origin and not from elsewhere. Before I discuss those findings, just a few comments. One of the obvious comments from veterinary surgeons when you mention this parasite is utter panic and fear. Are we all going to get infected because we touched these lesions in the abdomen of this dog? Just remember from the life cycle I told you, the only way people get infected is by ingesting eggs. You could actually eat that entire structure and nothing would happen. There's a few other issues I might discuss with you. All right? You get infected only by ingesting eggs. So, not by direct contact with the dog. However, it's important to appreciate that in Europe, about 20% of dogs with abdominal infections simultaneously have intestinal infections. All right? And because of that, we have worked with our public health counterparts in various parts of Ontario to test all people that have come in contact with the dogs to date. The blood samples from these people are sent again to the World Reference Lab in Switzerland, where they use 4 different antibody tests. And to date, fortunately, every single in-contact person has tested negative. So, in summary, what have I shown you? We've now seen 5 cases of this intermediate stage of Echinococcus multilocularis in dogs across Canada. All right? We think, from the Swiss experience, most of these infections are acquired by dogs ingesting eggs in their environment. Who else is in the environment of those dogs? And that's something to remember. People get infected the same way. The strange thing in all of this is these cases in dogs have only ever previously been described in high endemic, high risk areas. Canada would never have been described as a high endemic area for this parasite. Next thing to appreciate, of the 3 infections we've been able to type, infections in British Columbia, Manitoba, and Ontario, they're all European genotypes. And yet none of those dogs ever traveled to Europe. So have you any idea how we think those infections have got into Canada? Scott, you've been doing work recently looking at the numbers of dogs coming into Canada from outside North America. Are you prepared to put an annual figure on that? So, has anyone ever brought a dog into Canada? Try it. Okay, John, you have. It's extremely easy. You can bring a dog into Canada from anywhere in the world, and all you need to prove is rabies vaccination. That's it. You're just a piece of paper. In fact, ironically, a few years ago, I understand, I won't mention the province, but elsewhere in Canada, a clinically rabid dog was imported into the country because at the point of entry, the person that was responsible for the dog just checked the paperwork, didn't even look at the dog. If you bring a dog into Canada from, for instance, Central Europe, Switzerland, it can just come straight into this province. There's no requirement for tapeworm treatment to get rid of Echinococcus multilocularis. Countries such as the UK, Malta, Ireland require tapeworm treatment to prevent establishment of that particular parasite. So it shouldn't be surprising that an exotic strain of this parasite has got into Canada. The concern for those of us living here is, now that we have European strains in southern Ontario, those are considered more pathogenic for people. So, what are the public health concerns? Fortunately, every in-contact person to date with those cases has tested negative. What about the general population? What about you and me out with our dogs? Well, unless you go around actively eating wild canid feces, you have to argue the risk is likely low, but the bigger concern is where are these infections coming from? Is it dogs pooping into that environment, or is it more likely, and most consider it more likely, it is established already in the wild canid population? Collaborators out at Saskatoon worked up the Quesnel area in British Columbia where that first case occurred, and they sampled foxes and coyotes in that area and found 30% of those wild canids infected, also with a European strain. We haven't done that. Claire and I are hoping to start that in the near future, because that'll give a clear indication, I think, of the level of contamination in the southern Ontario environment. What about people, though? It's true there hasn't been a single human case diagnosed in Canada to date. Is it likely there are human infections? I've had long discussions with my Swiss counterparts in Zurich, and they look at me and say, you have to. You're the only country in the world that has got canine cases and not human cases. Everywhere else usually gets human cases first and then canine cases. You just haven't diagnosed it yet. Why? Is it the long incubation period? Potentially, and probably quite likely. Is it likely they're being missed? I had a long chat this morning with Rob Foster, who meets with the human pathologists. Any idea what proportion of humans that die in Ontario there's a post-mortem carried out? It's less than 5%, largely coroner cases. All right? And his general opinion was, if you have a subclinical infection with this and then die for other reasons, that will never be detected. If you're very elderly and diagnosed potentially with this, a definitive diagnosis will never be made. So it is quite likely that at least some infections will be missed. Is it likely that cases of this intermediate stage in dogs are being missed? Absolutely. If you look at livers and say, well, that's obviously tumor, why bother sending it to the AHL? All right, we've managed to persuade one of the drug companies to put up money to allow vets to do histopathology if their clients won't pay for it. And they're looking at the dog and thinking, this is an unusual age for a tumor, so a young animal, even if it's a boxer. All right, so we're trying to get the word out. If you're looking at an animal and it looks like a tumor, but there's something about it that makes you suspicious it could be something else, we're encouraging people to at least work those out, because there are public health implications associated with each of these cases. Is it likely that intestinal infections in dogs are being missed? Absolutely. I didn't tell you the eggs of this parasite in the feces of dogs look exactly the same as one of the common intestinal parasites of dogs that isn't zoonotic. All right? And we don't use methods at the moment to differentiate the two. And this is the sensitive issue at the moment, because the drug companies are starting to ask, at what point should a preventative program be recommended for dogs to prevent shedding of eggs? In Switzerland, if you have a dog or a cat that goes outdoors and hunts, the recommendation is that animal should be treated once a month throughout the year with praziquantel. Now that's an easy recommendation, but let me give you some perspective. If you have a medium-sized dog, the cost of that treatment once a month is about $17, just 1 month. And you need to do it monthly throughout the year. So the drug companies are waiting for us to make this recommendation. I don't want to do it without doing it in consultation with our public health counterparts. And I think the reality is, until there's a human case, the public health people are likely not going to come on board over this particular issue. All right? you can eliminate zoonotic risk from dogs by doing that monthly treatment. So that's where we are at the moment. This is a story that's very much developing and emerging across the country. There's multiple people across the country that have contributed to it. The people in Saskatoon, there's a number of vets in different practices. There's a whole wad of people here at OVC. And if I've left anyone out, my apologies. All right. Bruno Gottstein, particularly in Switzerland, has been incredibly helpful. That's everything I wanted to say. Thanks very much. Any questions? I'll repeat them just so that people can hear it.
What's the likelihood of some sort of vaccination strategy? And if there, like, I don't know how far vaccines have been developed, and would you recommend them more for targeting foxes or targeting the owners getting their dogs vaccinated?
So the question is, what are the prospects for development of a vaccine? It's rather interesting. There's a lot of tapeworms that a group in Australia have developed extremely efficacious vaccines to prevent the intermediate stage. So they're different parasites, but they're very closely related. All right. So for instance, Echinococcus granulosus, there is a vaccine to prevent sheep from getting it. No one's developed a vaccine for this parasite, but it could be a potential vaccine for dogs, although the reality is, even with the cases we're seeing, the market wouldn't justify the development of such a vaccine. No one's developed a vaccine for the adult tapeworm in the gut of animals. But it's a valid question. Yes?
Is there any antibody-based test to diagnose the infection?
Is there any antibody-based test
Yes.
to diagnose infection? That's the primary diagnostic method in humans. Right? They actually use 4 different antibody tests. And in fact, one of those tests has recently been developed for use on dogs as well. All right, so it is the primary, the detection of antibodies in people is the primary diagnostic approach that's used in addition to imaging. All right, yes?
Do the folks in Switzerland have any theories as to why it seems to be middle-aged people that are starting to be exposed to and develop this disease?
So is there any, why do the Swiss believe that it's middle-aged? So the average age of diagnosis is 52, so most people are getting infected in their late 30s, early 40s. I always thought kids and folks your age were the grubby folks in the environment. Well, seriously, so I don't know. Is it because it's that's if you're getting infected outdoors. The general feeling in what's happened in Switzerland is that there's been a sizable movement of foxes into inner urban areas. So then the life cycle sets up in inner urban areas with fox feeding on infected rodents. And then at some point, dogs get infected, or potentially cats. And those are the species that then come into contact primarily with people. So they think in Switzerland, most of the infections appear to be urban acquired, and it's associated with dogs. And what's the age group that lives more with dogs? Unlike vet students who spend their entire lives, I wonder whether that's the driving issue, that it's a dog-associated infection, and there's an elder generation who are more likely to come in contact. It is a reason for not sleeping in the bed with your dogs in these areas. Yeah, Dale.
You mentioned that the serologic test has been adapted for dogs. Has anyone done serosurveys yet?
So the question is, anyone who's done serosurveys in any animal population? No. I would like to in dogs, and potentially I think there's utility in wild canids, because I'd be surprised if it didn't also work. It's only been described in the last year, so it's something completely new for species other than people. There was a question over here, Brandon.
This question arises from your opening statement. You mentioned that if anyone asked you what the 3 most fearful parasites are, this would be one of them. What are the other 2?
So Brandon, how I live next door to you, I have no idea. Anyway, we don't a lot of the time, we just shout at each other. I said at the beginning of this talk I have 3 parasites that frighten me most. This would easily be number 1. The other 2 would be Balis ascaris, which is the raccoon roundworm, and the third one would be Taenia solium, which is a parasite of pigs and it causes neurocysticercosis in people. This easily would be number 1 though. I don't know whether Dale or Claire, you might argue differently for Balis ascaris. If I was a woodchuck, it would be Balis ascaris. But if I was a person, if I was a person, and that's been debated recently, I think it would be this particular parasite.
Andrew,
Yes?
I'm surprised that you don't have leishmania in your dogs as an imported parasite.
Oh, so Grant just said he's surprised I don't have leishmania in my top 3. My top 3 was the most frightening.
Oh, okay.
As far as what parasites concern me that are being imported, that's another talk, but there's a lot of dogs coming into the country infected, particularly from eastern parts of the Mediterranean. I better not mention countries. Yes, I will. Greece. Dogs coming into the country with infected with Leishmania infantum, which is zoonotic and cannot be eliminated from dogs. It's actually a bigger concern for dogs typically than this is. So there are a number of different issues associated with importation. Will?
So we're seeing an increased incidence in Canada. Do you have any information of incidents in the U.S., like the neighboring states like New York or Michigan?
As far as I'm aware, there certainly hasn't been a single case published out of the US. I've had long arguments with my counterpart at Cornell, Dwight Bauman. Is it likely your pathologists are missing it or misdiagnosing it? And he got rather upset with that. I don't look. You've lived further south than me in the US. There may have been a case, there appears to have been a case associated with the people at Louisiana State. It was presented at the recent meeting of the clinical pathologists, but I don't know, that's not published yet, and I don't know where it's thought that dog got infected. It's very strange. Why are we seeing these cases and they're not being described? I mean, talking to the pathologists here, you don't think they would be missed post-mortem. Yeah, okay. You do, Lou? No, okay. Yeah, Grant doesn't either. So I don't know. I've got bets with the people in Cornell there's going to be a US case within 5 years. So, yes.
Is it possible that it's linked to a massive decline in fox hunting?
Is it?
It's due to a massive decline in fox hunting in Ontario.
So is it due to a massive decline in fox hunting? Claire or Dale, can you comment on the change in the wild canid population in Ontario recently? Or Doug, has there been a significant change?
I think the fox population was held in check by rabies for a long time. But with the success of the rabies vaccination, I think you expected more of a rebound. But there doesn't seem to have been a huge increase in foxes, and I think some people believe it's because of competition for the coyotes.
Right. I mean, the first thing my Swiss counterparts was to ask me, do you have foxes or coyotes in inner urban areas? To which I said, as I found out recently, for instance, Todd Duffield the other night walked from population medicine to the parking lot beside the PHC and walked straight right past a coyote. So, I mean, they're common in inner urban areas. Is that fair, Doug?
Yeah.
Everywhere.
It's a growing issue.
Yeah.
Some 65 others.
So I don't know, but that might be what's driving this in part. Yes?
So for a lot of parasites like malaria, you start to see the emergence of drug resistance. So I'm just wondering if people have been treating for it's like decades. Is anyone looking at the emergence of drug resistance? And would you say, is this a greater threat than a missing Spider-Man lunchbox?
So the question is, how am I supposed to express that to an audience outside OBC? The question is the development of drug resistance in this particular parasite of greater concern than a stolen lunchbox? I'm working on drug resistance in other parasites. Is it possible that resistance could develop in this parasite to the drug that's typically used, which is praziquantel? It's possible. For instance, in parts of Africa, there's significant resistance to praziquantel in the parasite that causes schistosomiasis in people. So parasites will develop resistance to praziquantel. In the grand scheme of things, if you look at what proportion of dogs are being treated for this parasite with that drug, the highest level has to be in Switzerland, but they've only been doing it for about 10 years. There's no evidence yet. But I've given up saying resistance won't develop. Yeah, Brian.
Andrew, I was intrigued by the difference in incubation period in people and dogs. I mean, if dogs have been 12 to 15 years, you never see that.
Right, so the question is, why is there such a difference in incubation period? We don't actually know what the incubation period is in dogs, but it's likely no more than it's probably 1 to 3 years. I think part of it is driven by the issue. The interesting thing, a lot of people consider people actually relatively refractory to infection. And different species seem to vary in their susceptibility to the abdominal phase. So you can experimentally inoculate the same number of parasites into different species, and the chance of infection varies greatly by species. So dogs, if you have a dog that likes eating wild canid feces, all right? It's at much greater risk of exposure than your average dog. Just by the way, the first dog was known to eat fox feces in British Columbia and to roll in fox feces. I assume there's variation within dogs, but there's also variation exposure within the dog population depending on your lifestyle. So I'm sort of fudging the issue. I'll take one more and then I better say we're finished. Yes?
So you were saying that the infection most likely came from a dog that was imported from Europe. Is that, am I understanding that correctly?
If you believe the genotyping method that the Japanese group described, so it is specific for isolates from different parts of the world, then it would appear the infections we've seen to date in southern Ontario in dogs are European in origin.
So then my question goes, if the first Canadian case occurred in BC that led to rolling fox feces, then how did they get from the domestic species into the wild population where it's at 20 or 30%?
So the question is, how is it established? What we think has happened, talking to people in BC, there's a lot of people they know come from Switzerland every year to BC because they own property in BC. They travel backwards and forwards every year with their dogs. So a dog comes into the country with an intestinal infection. You almost never know your dog's infected because it doesn't make the dog sick. It poops into the environment. And if you like hiking, sort of traveling around the bush, so the dog feces is now in the environment. Any rodent that picks up that will get infected, and then the life cycle establishes in wild carnivores. The fact that 30% of foxes and coyotes in the Quesnel area are already infected would suggest it's been established for a lengthy period. We just don't have the resources to do routine surveillance in a lot of the country. Dale.
But are those 20 to 30%? They're not necessarily the European strain, are they?
The ones in the wild canid population in the Quesnel area actually are the European strain. And do remember, that's a province where it had never been described before. Now, that's biased by the lack of surveillance and the lack of a vet school. One day they'll put a vet school in BC. Yes, Rob.
Can this infect raccoons?
Sorry?
Can this infect raccoons?
Can this infect raccoons? It can certainly, raccoon dogs, which are not quite the same thing, will get intestinal infections. I'm not aware of infections described. Are you, Claire? No.
Not aware.
Yeah. Although, no. So the answer is no, there's nothing published. I'd better stop there because I've run over. Thanks very much for your time. If you have any questions, please feel free to get in touch.